Good evening, everybody, and I'd like to thank Cadilla for inviting me to take part in this conclave. I want to talk about obesity and osteoarthritis. Clearly there's a connection, but the connection is maybe not as simple as many people think. By disclosure, I am in receipt of an honorarium in giving this talk. Osteoarthritis, as we well know, is the most common joint disorder and accounts for massive disability amongst people as they get older. Hip and knee osteoarthritis is the most common, but obviously the prevalence of these diseases, the joints that are affected, varies from country to country. But we actually have to ask the question, is there a fundamental flaw in the design of our joints? The fact is, we actually live longer than evolution would say we should really do so. There's virtually no other animal species, mammalian species, that develops osteoarthritis. There are a few dog species that develop osteoarthritis because they have dysplastic hips. But degenerative osteoarthritis that we see in our clinical practice doesn't occur in other species. There are a number of risk factors, and we know those very well. But what about this design flaw? Well, the articular cartilage is a long way away from any blood supply. We all know what the blood supply of the knee joint is, for example, and that blood then goes into the synovial layer. The synovium is in effect one cell thick, and the ultrafiltrate from the synovial layer becomes the synovial fluid, and that provides the oxygen and the nutrients to the chondrocytes. And so these cells are existing in an environment which is not that conducive to actually surviving. Luckily, chondrocytes are relatively low energy using cells, but there's always a turnover of articular cartilage in all of its components throughout life, and particularly in younger people. Osteoarthritis, very common disease, vast numbers of people consulting about their symptomatic hip and knee joint osteoarthritis, and in my area, shoulder and elbow arthritis, every single year. Probably 5 or 6 million people in the UK suffer from symptomatic knee arthritis. Here in India, I can't imagine what the numbers are, but they must be absolutely vast. In Western society, the risk factors of knee osteoarthritis are very well known. So female gender, but that's partly related to the fact that us boys die before most women in most countries. Obesity, clearly a risk factor for the development of osteoarthritis, and previous knee surgery or significant trauma. Way back in the early 1960s, total meniscectomy was being performed, and it was clearly shown that somebody who had a total meniscectomy very rapidly developed osteoarthritis of the knee. And there are some occupations that may have an association with the development of knee arthritis. What about here in Asia? Well, hip osteoarthritis is a more uncommon, maybe not rare, but a more uncommon condition than maybe elsewhere. But certainly in the UK, there are now less patients having hip replacement than having knee replacements. Interestingly, this paper published in 2011 suggested the main strong associations for hip arthritis were injury, climbing stairs, 15 or more flights per day, and carrying heavy weights. But again, a weak association with being overweight or obese. For knee osteoarthritis, the risk factors are very similar to those found in the West, so it's a common pattern of older age, female gender, and of course, obesity. So within Europe, osteoarthritis is the 8th leading cause of burden of disease measured by this WHO measure, disability adjusted life years. And we know that there is a male-female disparity in that females get their problems a bit later in life than us boys. Now, the synovium it's really quite an amazing tissue within the joint. We must think about the whole joint when we're thinking about osteoarthritis. It's not just the articular surfaces, it's not just the subchondral bone. It's the whole unit that we need to think about. But synovium is almost unique within tissues within the human body. Synovial cells, they're a mixture of fibroblasts and monocytes. If they are damaged in some way, they proliferate, and most cells, when they touch each other, undergo a thing called contact inhibition. They stop growing, they stop migrating. Synovial cells don't do that. They continue to proliferate, they continue to migrate, and that's why we see this amazingly complex fronding, the villus formation, with splits within. This is uncontrolled growth of these cells within the joint. We conducted a very simple experiment a few years ago. It was a Japanese fellow of mine who actually did this work. The left-hand arthroscopic image, this is the shoulder joint, shows some very mild, wispy sort of synovitis. So there's been some problem there, not a particularly severe problem. The right-hand picture shows inflammatory synovitis in response to a more severe condition within the shoulder joint. And if we look at that with fairly simple histology, we can see that in the inflammatory synovitis, there are masses of inflammatory cells, particularly monocytes, being one of the two main cell types within the synovial membrane. And we did this as an in vitro experiment where we looked at proliferation and migration of these cells, and we fed them into one of the interleukins, some hydrocortisone and some hyaluronan. The lines here don't show up terribly well, but the most important take-home message is that when they're fed interleukin-1 beta, they actually continue to proliferate, but their migration is relatively inhibited. The other two substances, hydrocortisone and hyaluronan, had virtually no effect on these cells. So we need to think about the synovium in the etiology of osteoarthritis. So what is its role in both the etiology and the progression? Is it simply reacting to other insults that the knee joint or the hip joint is undergoing, or is it a primary tissue involved in the initiation of the osteoarthritic process? I would put it to you, in the patients who have so-called primary osteoarthritis, that the damage to the articular cartilage is that event 30 minutes after the Big Bang. So what happens between the founding of the universe and that 30 minutes? What is happening before the articular cartilage is being damaged? And I would suggest to you that there is now gathering evidence that there is an issue related to the synovium as one of those initiating factors. Obesity, a global problem, an incredibly massive problem affecting all communities. I do some work in Malaysia, and Malaysia that has the biggest problems amongst the Southeast Asia countries. 44% or so, according to figures from about 2013, are obese. The numbers are actually higher than that. And that compares to the other countries you can see there on that little schematic. In 2013, it was quoted that there are 2.1 billion people who are obese globally. That's obese, not overweight and obese, that is obese. Figures from 2016 suggest 2.8 billion people are obese. That is 30% of the world population are obese. Here in India, a quote from India Today 2014, 270 million people below the poverty line, but the third most obese country in the world. The Times of India 2016, India, most underweight people, ranks 5th in obesity. So in absolute numbers, 3.7% of the total number of obese people globally are here, males are here in India. 5.3% of the women are here in India. That is a phenomenal number of people. And even more worrying is the fact that both here in India and globally, 1 in 5, 20% of children are actually overweight or obese. It is said that obesity rates have become stabilized in Western countries. I'm not sure I quite believe that. You know, one of the things that we see is an increasing number, I still think, of obese people. And one of the aspects of that is that obesity has become normal. It's no longer regarded as being abnormal, that it is wrong for people to be obese. It has become psychologically a normal entity, and we must get away from that. We must understand that it is abnormal. Obesity rates are most rapidly increasing in poorer countries and affecting the poorer people in those countries. And this is where we also need to understand a concept of the malnourished obese. So these people are physically obese, but they have areas of malnourishment due to various micronutrients, which means that they are unable to, their cells are unable to perform the normal metabolic processes. And despite large amounts of money having been spent on public health initiatives, these have actually all failed and simply don't work. When we're measuring body fat, we need to know the distribution of the fat. We particularly need to know the proportion of visceral fat. The fat round your gut is highly pro-inflammatory and really very dangerous stuff. Subcutaneous fat is much less of a problem. And we can do measurements like hip-waist ratios. We can do bioimpedance assessments. We can do MRI, all sorts of things to measure the percent body fat and the relative proportions of these. But there are also some people who appear to have a normal BMI but have an abnormal lipid profile. Many obese people have an abnormal lipid profile, but we also have to be aware of this smaller group, an unusual group, who have a normal BMI, but they tend to have visceral fat, and they also tend to have abnormal lipids. But there is the obesity paradox. As one gets older into the 6th and 7th decade, it actually seems to have that being slightly overweight, not obese, but slightly overweight, does give some protection and reduces mortality rate. But we need to be very careful about this because the tendency is to become obese rather than just a little bit overweight. So what's the implications of being obese? Well, obesity has knock-on effects, medical effects on the whole of the body. So we see hypertension, we see osteoarthritis, we see type 2 diabetes, we see non-alcoholic fatty liver disease. We probably also see Alzheimer's, all associated with obesity. A metabolic syndrome is the medical condition that we see in patients who are obese. So metabolic syndrome is a disorder of energy utilization and storage diagnosed by a co-occurrence of 3 out of 5 of the following medical conditions: abdominal obesity, elevated blood pressure, elevated fasting blood plasma glucose, high triglycerides, and low HDL levels. So you've got 3 out of the 5 of that. You have this condition called metabolic syndrome. What metabolic syndrome means to us is that we have a chronic low-grade systemic inflammation, and that in itself is actually very dangerous. So when ordinary adipocytes become fat adipocytes, the fat cells lose their blood supply to some extent, become relatively ischemic. And as a consequence of that, they produce more pro-inflammatory adipokines and less anti-inflammatory adipokines, and then we get all the medical conditions that we now see very, very frequently, and at ages that are becoming really quite young in some societies. So in Malaysia, metabolic syndrome is now appearing in the 3rd and 4th decades, as opposed to later on in life. So our modern lifestyle predisposes to these conditions. Obesity develops that has effect at a cellular level. As we become increasingly aged, we develop these conditions that are the metabolic syndrome, and all the consequences of that, which become the stuff that our physician colleagues are struggling to try and control. So what's the cellular mechanism by which this happens? What you have to think about is that inflammatory cells, particularly circulating monocytes, are sitting in a soup of nastiness, circulating around our bodies. So if we are obese with abnormal lipid profiles, if we have got diabetes, there's abnormal glucose, all of this is circulating around the body. And these cells sit in this soup. So the monocytes become primed within the circulation. But one of the effects of this is that within the endoplasmic reticulum, where proteins are being put into their tertiary structure, the response is a thing called unfolded protein response. And that in itself encourages inflammation and becomes a positive feedback effect, so that once we've started this process, it becomes very difficult to stop it. So a combination of endoplasmic reticulum stress and oxygen stress through the production of reactive oxygen species gives rise to all of these problems, and within that, we need to add osteoarthritis. Just a slide aside, we've recently finished a study in Malaysia where we looked at 175 Malays, ethnic Malays in 2 different communities. 91% had a dyslipidemia, 43% type 2 diabetes, 56% cardiovascular disease of various sorts. A high percentage of these people were undiagnosed, and there was incredibly poor compliance with therapy in those who had had a diagnosis made. So what is the connection between osteoarthritis and obesity? We all see patients who've had obvious trauma to their knees, for example. We see actual physical damage to the articular cartilage, and in those patients, there's also a very early onset of synovitis. But probably there, the articular cartilage has been really, literally physically damaged. But in so-called primary osteoarthritis, where there's no clear history of trauma, there is an association with metabolic syndrome, and it is being now referred to as metabolic syndrome osteoarthritis. The important message here is that osteoarthritis is an inflammatory arthritis. It is a true arthritis. It is not an arthrosis. It is not just a mechanical problem. It is a true arthritis. So that there is an intra-articular inflammatory reaction mediated through the synovium. That's then exacerbated by systemic inflammation associated with obesity and diabetes, results in increasingly poor cartilage nutrition, and so the function fails, and so we see the progressive changes that we then see as a clinical entity of osteoarthritis. So osteoarthritis is not just the mechanical damage to the joint cartilage. There is a major inflammatory component, and so associate that with the metabolic syndrome that we find in patients who are obese, which is also pro-inflammatory. There are common cellular pathways that are seen as a consequence of this long-standing chronic low-grade inflammation. So we can put osteoarthritis rather cheekily in the middle of this map here, where it shows that there is a connection between the elements of metabolic syndrome and osteoarthritis, but it's also a two-way process. So the inflammation of the osteoarthritis adds to the systemic inflammation seen from these other conditions. We know from the UK National Joint Registry data that the number of joint replacements is still increasing, particularly knee replacements. But also more patients are obese, and those who are obese and receiving their first joint replacement are getting younger. So in their 6th decade rather than in their 7th and 8th decades. Very briefly, I'll just tell you about a little experiment. Well, actually, not that little. It actually involves 3,000 patients and over 5,000 blood samples, where we were looking at a combination of inflammation and function in patients diagnosed with osteoarthritis and undergoing lower limb arthroplasty. And we looked at various scores, but we also looked at this molecule called S100A8A9, and what that is actually a protein that's shed when circulating monocytes leave the circulation and become tissue macrophages. And we were initially interested in the relationship between macrophages and aseptic loosening, but it became apparent that in patients with osteoarthritis, before they get their treatment, have an increase in the level of this particular molecule. So in this is just 1,800 blood samples. I say we're over 5,000 blood samples now. And we measured the molecule itself, the S100A9, and we did various functional tests, questionnaires and such things. And in the UK, 87% of our arthroplasty patients were overweight or obese. Those who had had knee arthritis had a greater risk or a greater association with obesity. But also, interestingly, down the bottom there's a gender-related change in both platelets and monocytes, which are both involved in the inflammatory response that we see in all of these conditions. Doing a joint arthroplasty, hip or knee replacement works. We know that. The patients feel better, their joints function better, and surprisingly, so these plots here are from before the first arthroplasty to after the first arthroplasty, the level of measurable systemic inflammation decreases. So what that says is that there is a contribution from the joints to the systemic inflammation. And arthroplasty reduces that. So inflammation negatively impacts on joint function and, of course, general physical well-being. We can see in this experiment here that that there's a contribution in patients with primary osteoarthritis of inflammation measured by this molecule, which is fairly reliable as a thing to measure, that there is a contribution from the joints to the systemic inflammation, and by replacing that joint, we can actually reduce the level of inflammation, but it never goes back to normal. Partly that's related to the fact that the patients have more than one joint, but also they have these other components of metabolic syndrome. So part of this conclave is about innovation. And I have to say that I'm struggling to make any real comment about innovation in the treatment of osteoarthritis. As far as obesity is concerned, actually there's no innovation in the treatment of obesity as well. The most effective way of treating obesity is going to be nutritional education associated with exercise. And it's not a matter of me talking to a single person in a family. It's talking to the whole family, getting the whole family to understand the need to moderate their food intake. In the UK, we're going down a route of probable curb on various products, particularly sugar in fizzy drinks. And there are some pharmaceuticals that are used in the treatment of obesity, but actually they have massive side effects, and the reality is that people who are fat are repeat offenders, like felons. It's very difficult for them to stay thin, having got from a fat state. So what about osteoarthritis? Well, the standard therapies are weight loss and exercise. It's not very practical because of pain. Stem cell therapies are the flavor of the month. So mesenchymal stem cells, circulating stem cells, and adipose-derived stem cells are the areas that have sucked in vast amounts of research money. So mesenchymal stem cells are hypothetically the most effective. They're the right group of stem cells which can be driven down a cartilage lineage and so theoretically could produce hyaline cartilage within a damaged joint. But mesenchymal stem cells, the numbers diminish rapidly with age, and so by the time somebody's got to beginning to develop osteoarthritis, there are very few of these cells around. And actually they're hidden. They're hidden in lacunae within the bone marrow, and so they're actually very difficult to harvest. But also we need to know how to grow these things properly and effectively, and to make sure that they go down the cartilage lineage. Very difficult to do. There have been a whole variety of small-scale studies on isolated cartilage defects, all of which actually show fibrocartilage and never hyaline cartilage. Circulating stem cells. There's an orthopedic surgeon in Kuala Lumpur who claims that he can inject circulating stem cells into the knee joint and it cures osteoarthritis. That is a lie. circulating stem cells are mostly hematopoietic stem cells and will not go down a cartilage lineage, whatever you do to it. And so the claims of efficacy from just taking a sample of blood, extracting the stem cells and sticking them in the joint doesn't work. The experiments are fundamentally flawed. And so now the real flavor of the month are adipose-derived stem cells. So these are mesenchymal stem cells which are extracted from the adipose tissues, but we still have to ask the questions, will they proliferate and follow a cartilage lineage? We're getting the same stories as with mesenchymal stem cells derived from bone marrow, that these are wonderful things and they can do all sorts of great and brilliant sort of Harry Potter magical acts within the joint. But actually there's virtually no data to support that. The only thing that was found in a very early study, very small numbers, was some pain reduction. But that's not surprising, seeing that it was a combination of adipose stem cells and hyaluronan. Though hyaluronan itself is actually quite a difficult substance to put in the joint. It depends on the size of the molecule and all sorts of other things like that. So whether any of these stem cell therapies will be the answer remains to be seen. They probably will be the answer in the end, but not at the moment. One of the things you have to really consider is the environment. The normal knee is a lovely environment, isn't it? Those wonderful cartilage cells get all their nutrition from the synovial fluid, and it functions perfectly. But as soon as the osteoarthritic process starts, and in the face of this circulating nasty goop that these cells have to wander around in, then the knee joint environment, the hip joint environment becomes hostile to any cells that are put in there that are trying to repair the cartilage. So the knee joint in somebody who has obesity and metabolic syndrome looks like really it's a nasty place for those cells to be. The chondrocytes need their nutrition. They need to be loaded as well. All mesenchymal cells need to be loaded in order to function and develop. But also, what sort of scaffolds do we use? Do we use a 2D or 3D scaffold? What sort of materials? And do we need growth factors? At the present time, there are virtually no experiments looking at mesenchymal stem cells or chondrocytes or any other of the stem cells that are around in the abnormal environment of a person with osteoarthritis or an animal model. We are just about to start those animal studies to look at what happens to these cells in an obese and diabetic rat. Other things, PRP. Well, there's absolutely no evidence whatsoever that PRP works at all in anything, and certainly not in osteoarthritis. There's lots of companies and lots of doctors making vast amounts of money about injecting PRP, but it does absolutely nothing at all. It's only ever been shown to maybe reduce pain for a very short period of time. But if you look at platelets, they are complex. 1,500 different growth factors at least within a platelet. What are they all doing? We don't know. Hyaluronan, the FDA recently actually ruled that putting hyaluronic acid into a joint is a waste of time. Hyaluronan is a complex molecule. Some size parts of the molecule are pro-inflammatory, some anti-inflammatory. Get the wrong one and you're actually going to increase the inflammation. So there's no point in injecting hyaluronic acid. Again, efficacy, let alone anything else, has never been demonstrated by injecting the joints. So patients who are obese with osteoarthritis require joint replacement at a mean age of 59 years. This is from our own data. Patients with age-related hypertension, 74 years. So if you've got OA and metabolic syndrome, obesity and metabolic syndrome, 15 years, you are likely to need your first joint replacement 15 years younger than if you just have age-related hypertension and things like that. So obesity in relation to osteoarthritis is not just a problem of weight. We have very good existing treatments, but what's the future? Probably stem cells, but that still needs a lot of work to be done. So obesity, metabolic syndrome, osteoarthritis, they all contribute to the total systemic inflammatory load. Joint arthroplasty reduces that load, but it never goes back to normal. Of course, osteoarthritis usually affects multiple joints, and so there is continued contribution to the systemic inflammation from each of those joints. And most of these patients, certainly in our study, have at least one, if not several, comorbidities. So the inflammatory components of obesity and osteoarthritis interact. The molecular mechanisms are probably related to endoplasmic stress response and the production of reactive oxygen species. Joint replacement does, however, reduce inflammation. So we have this global problem of obesity and osteoarthritis. Patients needing arthroplasty, particularly of the knee, are getting these first-time replacements at a younger and younger an age. We need health improvement strategies that target both problems, both the obesity and the osteoarthritis. And we need new osteoarthritis targets in order to effectively treat the disease at a much earlier stage. But that needs fundamental research, not product development at this time. Thank you very much.